welcome in today's nursing webinar session. Myself, Shanti Bhattacharya, the VP Nursing, and we are going to discuss about the two very minimally, urology procedure called URSL and PCNL. Okay, so let us see who we have in today's session. It is my privilege to welcome Dr. Surya Prakash Garu, who is our very senior urologist, transplant, robotic, and laparoscopic surgeon. We cannot just measure or mention the about him because he's very humble and very dynamic and very able and highly skilled doctor. We have very happy to have him in Yashoda Hospital. He's from Somajiguda unit. And let me also welcome Miss Vijaya, who is our very able, fast and furious nurse manager who heads the medical and surgical department. And I welcome you, Vijaya.
Thank you, ma'am.
Yeah, you can share the second slide and let us see the prevalence. As I would like to also know from sir that as we all know, the kidney stones are in rise and the prevalence around maybe 1% of emergency admissions we always get to see because of the chronic pain and complications, and it is a 12%. It is again measuring with the worldwide and also north part of India where it is more than 15% as per the National Institute of Health. So here we would like to ask sir opinion why the rise is so high and especially in the northern part of world. Yes, sir.
Yeah. Thank you, Shanti Madam, for first of all having me here. It's my pleasure and privilege to interact with you all. And that one is a subject which is very close to my heart, kidney stones. So most of the viewers are very curious to know about kidney stones because it's a very common problem. And nearly 50% of our outpatients, they come with this problem. This problem has been on the rise. If you see in the last few years, the outpatient visits for kidney stones has been on the rise. So what's the reason? The most important reason I cite change in our lifestyle. So we have become very busy. All of us have become very busy. We stopped drinking water, which is very important to prevent stone disease. And the way we eat our food, it has changed a lot. We consume, most of people are very busy. We eat fast foods, junk foods, especially the children, you see. The disease which was once upon a time common in adults has become, now we are seeing more of pediatric patients with stone disease. We see 3 years, 5 years children coming with stone disease. What is the reason? The diet is one of the most important reasons. If you consume a lot of junk foods, which have got many chemicals, added additives and salt, that predisposes to stone formation. And extra salt in the diet, the salt contains sodium. The sodium gets exchanged for the calcium in the renal tubules called nephrons, that again predispose to stone formation. So to put it in action, inadequate water intake. Water, let it be any water. Don't. Some people ask us, shall I drink? It's like mineral water or purified water. Any liquid is good enough. Good amount of water intake, less salt, less purine intake. Meat, a lot of protein gets converted to uric acid in our kidneys and gets deposited as stones. So these are the three most important things. If you don't take enough water, you'll form stones. If you eat excess salt, you'll form stones. If you eat excess protein, like eating a lot of non-veg, that predisposes to stone. Rest are all secondary, but these are the three important reasons I can cite.
So let us see. This is going to be a very interesting session. Let us see what we have in today's session. Over to you. Share the slide for the second one. Yes, so you can go ahead, Vijay.
Good afternoon, everyone. Thank you, madam, for this opportunity. Let me start PCNL. PCNL is a percutaneous leptolithopsy when kidney stone is above 1.5 centimeters to 2 centimeters. Indications for PCNL: patient has large or complex stones, patient having continuous pain, any obstruction, and a recurrent stone formation.
So, sir, here as we are discussing about the stone size and we can see also in the images, can we, in this point of time, can we go for the conservative management, and what is your expert opinion for the learners who are viewing this?
Obviously, nobody wants to have any surgery on them, no? So everybody wants the stone to come out. So basically, it depends on the stone size. We take 2-3 criteria when we give them conservative management. Location of the stone. Suppose the stone is present in the ureter, lower part of the ureter, close to the bladder, where the chances of coming out are high, compared to a stone which is present in the upper part of the location of the stone in the urinary tract. The closer it is to the urinary bladder, the chances of high coming out by itself. Second is size of the stones, because the ureter has got a very narrow caliber. So it will allow easily about 5 to 6 mm stone to come out. If anything more than 6 mm, it causes a lot of pain and it doesn't come out so easily. So any stone less than more than 6 millimeter stones in the kidney, they are unlikely to come out. So we advise treatment for larger stones and stones in the kidney. But if you find the same 6 mm stone in the ureter, we tell them conservative measures like take more of water. There are certain drugs which dilate the lower part of the ureter called alpha blockers, which we use for prostate also, like alphazocin, tamsulosin, cerebrosin. These drugs dilate the distal part of the ureter, so that stone comes out. Hydration and alpha blockers. This part of the treatment called medical expulsive therapy. It's called MET, medical expulsive therapy, which help for the stones to pass out spontaneously, spontaneous stone passage.
Yes. Next. Yeah.
Let us also discuss this URSL. URSL, urethrorenolithotripsy. It is a endoscopic procedure through endoscope to removal urethral stone of 5 mm to 1.5 cm through a thin tube inserted into urinary tract and removal of stone. Same can see in the picture. Coming to indicators. Stone located in lower, mid and upper ureter.
So, sir, I think this same mechanism which applies here also, and I think these endoscopic procedure also is a laser guided, where it is, done.
Yeah, as Vijay has rightly pointed out, the stones can be removed easily with a ureteroscope. Nowadays, we've got the technology has changed. Last few years, we've got digital technology, digital scopes. Scopes have become very thin. Now we can access any part of the urinary tract, right from the urinary meatus, right up to the calyx in the kidney. So we can reach stone anywhere in the urinary tract with this, as she has shown the picture. The scope is called flexible ureteroscope. So these have become very popular in the last 10 years. Earlier days, we didn't have these kind of scopes. So these scopes, the tip of the scope bends. So whichever way you want it, we can deflect it. So you can go from the bladder into the ureter, into the kidney, and whichever part of the kidney you can deflect, reach upper calyx, middle calyx, lower calyx, go to the stone, see the stone, and break it with laser. That's the beauty of this. It's called RERS, URSL. So when you break the stone in the ureter, it is called URSL. URSL stands for urethrorenoscopic lithotripsy. This procedure is done for stones in the ureter. So when we use a flexible ureteroscope to treat stones in the kidney, that procedure is called RIRS. RIRS stands for retrograde intrarenal stones.
Yes.
In the first slide, Vijay has told about PCNL. PCNL we usually do for larger stones more than 1.5 centimeters in the kidney.
Yes.
So PCNL stands for percutaneous nephrolithotripsy.
Yes. Yes.
Let us see what are the major causes of stone formation. As you all know, urine contains calcium, oxalate, sodium, phosphoric acid. When the fluid cannot dilute in urine, then stone formation happen. Possible causes includes drinking too little water, physical inactivity like obesity, food with too much salt or sugar, proteins, taking excessive vitamin D supplements, and oxalated food like spinach.
So we will also, I think, sir, you will also agree that these are the possible causes, and maybe the learners or the new nurses, who they do not know the characteristics of urine when we do not, drink, and this becomes, stone formation.
Urine is a complex solution. It contains so many solutes in solution. They don't form crystals. So I'll just give you a small example. Take a glass of water and keep on adding salt. Initially, you don't see it gets dissolved. You add 1 spoon, 2 spoons, 3 spoons. At one point of time, it doesn't dissolve. That means it has reached the stage of supersaturation. So all these, whatever, let it be calcium, sodium, oxalate, they are already present in the urine, but they are in a solution form. When the concentration of oxalate, calcium exceeds the capacity of the urine to keep them in the solution, they form crystallization. So that cutoff point is called supersaturation point. So if more of the calcium is present in the urine, at one point of time, it forms crystals. Only crystallization. So our main aim is to keep all these solution. How do we keep them? Either by drinking a lot of water, increasing the volume of the urine, or by reducing the concentration of these solutes. by eating less meat. Uric acid. Uric acid comes from protein. So if you take too much of calcium supplement, again they take more of calcium in concentration, increase in the urine. More of salt, sodium gets exchanged for calcium. So if you take more salt, more calcium in the urine.
So that's the reason I think before we take any of our dietary, modification or any supplements, we should always, contact the expertise, and then only we can go with all this, supplements, as you have rightly mentioned, calcium, vitamin D. Yes.
Another important thing is citrate. So citrate is one substance in the urine. It prevents crystallization. So though calcium may be present, it doesn't form crystals when citrate is present. So citrate is good. So it counteracts the stone form. So we tell the patients to take a lot of citrus fruits. Take one lemon juice every day. Eat one orange every day. So as you tell, one orange a day keeps stones away.
I myself consider myself as a very high citric lover, so I can just quote your yes. Yes.
So there are certain foods which are good for preventing stones and such which are prone for stone formation.
Yes.
As we already discussed, salt intake, urine intake, a lot of eating dry fruits,
Yes.
they also predisposed to stone formation. In general, there is some myth among the general public that we eat like tomatoes, spinach. They per se do not cause, because the dietary oxalate what we consume and what it forms stones is very less. So there are a lot of mechanisms in our body which counteract the dietary oxalate.
Yes.
So nobody eats 3 times a day spinach all 7 days a week. So we don't tell the patient to avoid all these foods. You can eat tomatoes, you can eat spinach, but overindulgence in anything is not to be done. Overindulgence.
So these are, I think, the myth which is going in the mindset of the population. Yes.
They ask us, shall I eat this vegetable, that vegetable? You can eat anything, but to prevent stone formation, keep the solutes in solution, drink more water.
Yes.
That suffices.
Yes, Vijay.
Let us see signs and symptoms of kidney stone formation. Patient have continuous pain, fever, vomiting, dizziness, blood in the urine, and backache.
So all the flank pains are to be considered as a kidney stone pain, or any, as we see the similar mimic symptoms in the UTI as well.
Not really. All flank pains are not kidney stone pains, but we have to exclude kidney stones. There are so many structures. From skin to kidneys, we have muscles, ribs, bones, spine, disc.
Yes.
All they have similar kind of pain. But classically, the stone in the renal pelvis or ureter causes a severe colicky pain. If the stone is in the ureter, very sharp pain. It comes and goes. It's a colicky pain, and it radiates down to the lower abdomen. So these are certain characteristics of it. If the stone in the upper ureter, the pain radiates to the genitalia also. If the pain is the distal ureter, it irritates the bladder. You'll have pain. Along with that, you have irritative voiding symptoms like frequency, urgency, burning, urination. So flank pain is an important thing, but it could be caused by so many other pathologies. So we investigate and then come to the diagnosis.
Look at the images types of kidney stones, like calcium stone, uric acid stone, steroid stone, cystine stone, and also called large kidney stone, Stockholm calculi.
So while making the PPT, then only I could understand the Staghorn calculi. Sometimes we used to see this condition very rarely, and it looks like the antlers of the deers.
Yes.
So yes, as you were rightly saying, the urine has a lot of composition by default. So do we also get to see the Staghorn calculi, sir? I think.
Yesterday only we operated one patient, typical Staghorn stone. So of late, because a lot of awareness, these kind of stones we are not seeing that common. But these are all infections. Staghorn stones are infection stones. So sometimes they can be silent. They don't cause much pain because they are present in the kidney. They silently increase in size. They may cause mild pain. They can cause UTI. But these have to be completely removed. If you don't remove the stone completely, there's a very high chance of recurrence. So we remove the stone, put the patient on long-term antibiotics to prevent recurrence because they are caused by infection. Compared to the stones like calcium stones, uric acid stones, they are related to dietary intake. But steroid is basically a composition of magnesium ammonium phosphate. It's kind of three components. Steroid stones are made up of magnesium ammonium phosphate, They are basically infection stones. Very rarely we see even calcium stones also taking this big shape. But most of these stag-on stones, or they stag out because of the extension of the calyces of the kidney. So they form this typical shape. Uric acid stones, again, as I said, because of excessive urine intake. Uric acid stones are usually radiolucent. If you take a plain X-ray KUB like this, we miss uric acid stones because they are radiolucent. So they are seen only on ultrasound and CT scan, not on X-rays. Whereas the calcium stones, cystine stones, they are easily visible on the X-ray. Stuart stones are in between. They're not that radio opaque, but faintly radio opaque. This is how we diagnose them. But nowadays, any patient coming with the flank pain, when we suspect a stone disease, we just first subject them to ultrasound because they're very easily available non-invasive modality of investigation. And when the ultrasound shows stone or there is indirect evidence of the stone like hydronephrosis, then we go for a plain CT KUB. CT KUB 100% diagnosis stone anywhere in the urinary tract, whatever may be the size of the stone, even 2 mm, 3 mm, we can easily diagnose by doing a plain CT KUB.
So it is very interesting to know these properties of stone and how it is, in a form of salient features and then the, protrusion of the same. Thank you, sir, for telling us the beautiful update on this. Yes.
Yes, Vijaya.
As you can see the images, stone formation in the kidneys and stone formation in ureter. Let us see the scopes we are using for this scopes which we are using for the procedures.
Can you just go back? Sorry to interrupt you. Can you just go back?
Yes, sir. Yes, sir.
In the right side picture, you can see a thin tube. You can see you have put the cursor over the stent.
Yes.
There is a thin tube which is coiled above and coiled below. That is called DJ stent. So you people have to be aware of this because any procedure in the urinary tract, suppose we remove a stone, we put the stent just to facilitate proper drainage of the urine. Any small fragment, they will come out. So we tell the patient they have to come after some time for stent removal. We tell the patient we usually remove after 2 weeks, 3 weeks, or 4 weeks. So when you take care of these patients in the wards, you also should be aware of them. Tell them, apprise them that they have got stent in their body and it has to be removed because they don't feel the stent. Sometimes I'm perfectly all right. I got discharged. Why should I go to the hospital? So we have to tell them that there is a stent in your body. It has to be removed after an interval of time. And if the stent is not removed, again, it's a foreign body in our body. Again, stones can form over the stent. And removing these stones over the stent is a hell of a job. So we sometimes, in spite of telling many patients, they don't come to us in the follow-up. They come after 2 years and 3 years. And when they come, you see a big stone formed all over the stent, right from the kidney to the ureter.
It's coated. The stones are coated with the stent.
So you, when you do as a nursing care, when you see the patient after this, you tell them, you just check with the case sheet whether the stent is present or not, and tell the patient there is a stent in your body. We are giving you a date, and you come on that date and they get the stent removed. It's a very small procedure, OPD procedure. 5 minutes job, they remove the stent and send them.
Yes.
Okay. Yeah. Go ahead. Yeah, you are showing them instruments, man.
Yes.
Go back.
Go back here.
So this is the instrument on the left side. It's called nephroscope. This instrument is used to work in the kidney. What we do in PCNL, we make a small hole in the back. We dilate the tract right up to the kidney, into the kidney. We put a sheath, and through the sheath, we pass this instrument. Nephro means related to kidney. Scope is visualization of the kidney. So we use this scope, go inside the kidney, see inside the kidney where the stone is present. Once you see the stone in the kidney, break it by passing a small lithoclast through the instrument. These are all the accessories. You are seeing on the right side, forceps like thing, long forceps like thing.
Yes.
These instruments go to you can see a blue cap on the nephroscope. So these instruments will go through this blue cap into the kidney. We pass through the instrument into the kidney, break the stones and remove all the pieces.
Yes.
So this is about PCNL.
So I think, Vijaya, next time whenever you receive these patients with these conditions, you will be very able to train your next level.
Okay,
Yes.
ma'am. Thank you. Sure. Let's just discuss about a pre-op investigation for both procedures. We should do CT KUB to rule out renal cannuculi size, location. Also, we can do X-ray KUB for amount of stone. Blood investigations like CBP, urine, RFT, PT with INR, viral screening. Keep the patient NBM for 6 hours minimum. Part preparation, nipple to mid-thigh, PAC checklist. Start blood thinners 5 days prior to surgery. Pain medication, especially tramadol. Shift to OT. Strictly follow all patient safety goals.
I think these are the very core instructions which all the nurses in the ward they should follow. Also, the OT nurses, when they take over, they must also take over with the reports and all the blood reports, and any parameters which is abnormal should be always escalated to the primary team. I think, sir, you will also agree with the same.
Yes, perfect. Preparation, pre-op preparation is in your hands. If you prepare the patient well, we can do the surgery well, and we can give a better result.
Yes.
So it all depends on you, how you prepare the patient and give to us. All these in whatever she has mentioned. Another thing, you have to make a surgical profile. So you have to check all these pre-op investigations like viral markers, hemoglobin. I think you mentioned, I think now, yeah.
Yes.
Creatinine, all these things are. Patient has to be optimized, and patient has to be properly counseled. Tell them that you are going for this procedure. There is every chance of the stone may not completely come out. So we counsel them. So this is an endoscopic procedure. If it's not in sitting, next sitting will remove this procedure. So we counsel the patient well. And for PCNL, definitely you have to stop blood thinners because we are making a hole in the kidney. If the patient is on blood thinners, it's very difficult to control the bleeding. But for these latest procedures like RIRS, what we have discussed earlier, we usually don't stop because we are not making any cut there. We are just going into the urinary tract, and when we are using laser, we don't injure any local tissue. So sometimes we don't stop blood thinners when the patient is going for ureteroscopy or RIRS. But for PCNL, definitely you have to stop blood thinners. And another important thing is patient has to be infection-free. Whenever we do this procedure, urine should be free of infection. So do a complete urine examination, and the urine shows pus cells, you have to do a urine culture. Because when the urine is infected, when the patient has got infected urine, you should not do any of these procedures, because then we will be directly introducing the bacteria into the bloodstream.
So post-procedure, you advise us to go for the urine culture, sir?
Pre-op also, pre-op.
Also.
If the culture is positive, we don't operate.
Yes.
We treat them with the culture-sensitive antibiotics, make the urine culture free, infection-free, then operate.
Then we go for surgery, yes.
Yeah. That's very important, pre-op cultures.
Coming to post-operative care management, pain management and reassessment, encourage the patient to take oral hydration, monitor intake and output. Any hematuria is there, we inform to the primary team. Foley's care be given. Observe the surgical site. X-ray care be for the check for stent site. Follow up and review in OPD. After 1 month, visit for the stent removal.
I think these are the post-operative guidelines as well for the bedside nurses.
So these are all the minimally invasive procedures.
Yes.
For PCNL patient, we have a little bit of pain because there is a small hole in the back. So we give them analgesic. Usually we avoid NSAIDs in urology and nephrology because they are, if you give high doses of NSAIDs, they are nephrotic. NSAIDs are non-steroidal anti-inflammatory like diclofenac, aceclofenac. We give them paracetamol, which is kidney safe. And if the pain is more, we can give them tramadol, or a combination of paracetamol and tramadol is good enough for pain relief.
Yes.
Hydration, because we are not any manipulating gastrointestinal tract. So we tell them to start taking liquids maybe after 4 hours after surgery. And the next day they can consume normal diet, they can have breakfast and take more water. And especially whenever there is a urine catheter, whenever there is a drain, you are well aware of monitoring the intake output chart. That's very important. You have to alarm the surgeon about if there is a hematuria. Sometimes it is possible when we do a PCNL, there can be bleeding. So watch the urine bag. What is the color of the urine? Mild hematuria is acceptable, but if it's bright red, then we inform them. The urologist may do some procedure, or they give some medications like tranexamic acid. Sometimes we may have to take the patient to angiogram cath lab, do angioembolization. There can be severe bleeding after PCNL sometimes because we are making a hole in the kidney that can injure any major blood vessel. If the bleeding is not controlled, there are some instances where we have even angioembolized the blood vessel with the cath lab.
Yes.
Foley care is very important. Yeah, I think we have to do. Usually we do an X-ray the next day morning. Next day, the day after the surgery, we do an X-ray. That is to see whether all the stones are completely cleared or not, and also to see the position of the stent. When you go for rounds before we come, to take the X-ray, show to the patient, this is your stent in your body. So this has to be removed after a definite period of time, usually 2 to 4 weeks. And you can even counsel them about the dietary advice, about the antibiotic. Usually we give them an antibiotic for a week, not more than that. Sometimes we give for patients who are in high risk, like elderly patients, diabetic, we give prophylactic antibiotics till the stent is removed.
Yes.
That's it.
Let us discuss benefits of PCNL and URSL. High success rate, improved kidney functions, precision and efficiency, reduced complications, shorter hospital stay.
Yeah, correct. So as we discussed, PCNL is usually done for bigger stones which are more than 1.52 centimeters. So 20 years back, all these stones were removed by open surgery, very morbid procedure. We cut, cut the rib, open the abdomen, go to the kidney. Now all those, I think the last open stone surgery done in this hospital, maybe more than 10 years. When I came, we have not done any open stone surgery. All these are done by endoscopy. So you can see the patient lying on the back. The surgeon is making a small hole. We just pass a needle into the kidney. Once we confirm that we are in the kidney by doing laparoscopy, we pass a guide wire through the needle into the kidney and dilate the tract. So we are not causing any harm. The injury to the kidney is of the needle size. The next whatever is, we are just dilating the tract, making the tract wider and wider. Usually we dilate up to 20 French, 22 or 24 maximum to accommodate our nephroscope. And then we have seen the picture. So the tract should be wide enough to accommodate the nephroscope. Go inside the kidney, visualize the urinary inside the pelvic calyceal system, see the stone breaking. It's a very effective because you are inside you are directly seeing the stone. You're precisely seeing the stone breaking and taking out all the fragments. Complications are there, but they are less. If the procedure is done properly, and with taking all the precautions, complications are less, but still there can be some alarming complications like hemorrhage. As I said, there can be severe blood loss when we injure a major artery. So the main crux of this procedure is getting a proper puncture. You have to target the exact calyx exactly. If you get a proper puncture, that means the PCNL is successful.
So that is the reason I think highly it is very much opted out by the patients, and because of its a shorter hospital stay and safe outcome. Yes. Yeah. Vijay, you can go to the diet slide.
Within 2 days.
Let us discuss risk factors and common URSL and PCNL. Persistent stones, bleeding first site, any infection from surgical site, bleeding during postoperative, continuous pain, discomfort, urinary tract infection, and temporary urinary frequency or urgency.
As sir has rightly mentioned, yes, you can go to the next slide again. And I think, yes, let us also understand, because as a healthcare professional, as you have already rightly mentioned, we skip or we forget to drink water. Again, importance of hydration and diet by you, as we have seen. Next slide, Vijaya. As we have seen the diet chart, which is, I was going through. It is very beautiful, which is, done by you all, your team, like you always advise, and this handouts are being handed over to the patient, and attender also are being, educated that drink plenty of water, avoid a lot of citric juices, reduce salt intake. These are very, as per, even I can see the, as per the, the classification of stone also, you have mentioned that reducing sodium, milk products, all that, very beautiful. And I think the exercise also play a role in, I think, to make the person fit and avoid the kidney stones. Yes, sir. So would you, we have come to the end of the session now, and you can come to the conclusion, Vijaya, and sir, you would like to pass the message as the conclusion part to the learners out there. Come to the conclusion slide, Vijaya. Yes. Sir, we like to hear from you the conclusion part, sir.
First of all, I congratulate Vijaya for doing a great presentation.
Thank you, sir.
Doing a great job. So I think she has very well. You can share this presentation with your colleagues. So that it would be nice. Anyway, this is available on the online.
Yes.
This is good. You have divided the dietary advice as per the type of the students. That's fine. So basically, my advice to everybody is, as your nursing staff, you should know about this procedure. What procedure the patient is undergoing.
Yes.
As you already described, pre or post-op care. And most important is prevention. Prevention of the stones is very important. That is in your hands, because most of the time you spend with the patient than what we spend. So tell them proper dietary advice, give these charts, handouts, so that they will not come back with stones again and again. If we can take care of the kidneys. So drink a lot of water and protect your kidneys. from
And I
kidney
think all these charts, we can also take one and start following this. It is very important and lot of things which we were not aware. But thank you. Now we will have to have a lot of water and then make sure that we are, we prevent this situation. Thank you so much for your valuable time and input, sir. Thank you so much. Thank you, Vijaya. We end this session here. Thank you.
Thank you, madam. Thanks for
Thank you.
all the best. Thank you.
Thank you.